Good evening, everyone. So, in continuation of our ongoing academic programs, today we are going to discuss very important topic that is regarding the Onco ICU. And as we all know, more and more cancer-related options are available. More patients are opting for these treatment options, and definitely they will have some complex and unique emergencies related to maybe cancer per se or the drugs which can be handled in a dedicated onco ICU like tumor lysis syndrome, CRS, and ICANS, etc. So the focus should be on the reversibility of the acute illness rather than the label of cancer itself, so that patient may return to its normal functional status which was before that illness, so that patient can further continue with chemotherapy or their whatever care was planned. So, with this intent, around 3 years back, we started Onco Critical Care Society, and I'm really glad to see that now at least people are talking about Onco ICUs, and now it is being recognized as a subspecialty. So, for this important discussion, me and Dr. Saurabh, on behalf of Onco Critical Care Society, we welcome our esteemed panelists. Our first panelist, Dr. Avdesh Bensal. He happened to be my teacher as well. Good evening, sir.
Hi.
He's the senior consultant, Department of Respiratory Medicine, Sleep Medicine, and Critical Care in Indraprastha Apollo Hospital, Delhi. Then our second panelist, Dr. Chitra Mehta. She is
Good
senior
evening.
director.
Good evening,
Hi,
everyone.
ma'am. She is Senior Director Critical Care Medicine at Medanta Hospital, Gurugram. Then we have Dr. Vandana. She is Medical Director and Head Critical Care Medicine in Guwahati. Then we have Dr.
PLS
Sangamitra
Hospital.
Mishra. Sorry, ma'am. Did I miss something?
I said in PLS Hospital.
All right, ma'am. Sorry, I think I missed that. And then we have Dr. Sangamitra Mishra. She is Dean and Principal Professor Critical Care Medicine, IMS and
Hello,
SVM
everybody.
Hospital, Bhubaneswar. Welcome, ma'am. And to moderate
Good evening.
this panel discussion, we have Dr. Rakesh. He is Consultant Critical Care Medicine in Apollo International Hospital, Guwahati. And I welcome Dr. Rakhi. She is HOD Anesthesia and in charge ICU in Health City Hospital, Guwahati. So now I'll be handing over to Dr. Rakesh and Dr. Rakhi for moderating the session, please. Dr. Rakesh. Dr. Rakesh, you're not
Audio.
audible. You have
Before we start,
now.
we would like to hear a little from Dr. Saurav. Just opens the floor, the idea of the society, the meet, and what is it that we can look forward to.
Okay, I think already Praveen has highlighted. We like when we started Onco Critical Care Society, when we like started our anesthesia or critical care journey. That time, ICU was not a place for oncological patients. But with the advent of newer drug, now cancer is not so lethal. It is a more disease that can be chronic or that can be controlled. So now as the lifespan of people increasing, so we'll get obviously get more and more patients who had cancer, and so we need to have ICU to cater them. And in that process, we also need to change our concept or our narrative that onco patient can be treated in the ICU. To learn about oncocritical care, we started the society in 2023. Then we like registered officially in after a year. Then we had till now we have conducted two conferences in 23 and 24 and 25. At the same time, we also started a journal called Oncocritical Care Journal, and also we publish book mainly that is a CCS Oncocritical Care Society Manual of Medical Emergencies is in oncology. And presently, we are trying to develop two guidelines. One's on uh, difficult area in oncology patient, and second one is admission trials and research criteria in oncology. We need your support and guidance of seniors like you. And thank you for joining this webinar. It is a great encouragement for us. Over to you, Rakesh.
Yeah, and a lot of things have changed here in Assam, particularly with the Tata Group coming, large cancer hospitals being built in the government
Yes.
sector, in the private
Yeah.
sector, a lot of pet cities all around. a lot of linear accelerators in places, robotic surgery is being introduced. And then we have these smaller hospitals being set up at every district headquarter, medical colleges coming up. And that is when we realize that there's a major load of patients which we're probably not as used to seeing or treating. And, as we deal with intensive care, we are also dealing with patients who are now living longer with their cancers. And, there are larger spectrum related to both disease, treatment, and the morbidity of age, everything together. So I thought it was relevant to know what exactly is happening, and who better than Dr. Avdesh Bansal to tell us uh, what's this changing landscape? What has he seen over the years? What's changing in oncology and oncocritical care? And where do we see ourselves now and in years to come? Dr. Bansal, we would like to hear from you.
Sure. Yeah, thank you, Rakesh. I'd like to thank Dr. Praveen and Dr. Das for inviting me to speak on this very, very important subject. We started ICU long time back in 1997 in Apollo Hospital. I remember we were one of the first groups to have what is known as critical care units in two medical ICU and gastro ICU. And I remember at that point, whenever somebody would try to admit a cancer patient, we would just say, the patient is going to die. Why do you want to admit this patient to ICU? So the belief was that they had poor prognosis, very bad outcome, and the treatment options were really, really limited. But things have changed. Things have changed dramatically because of advances in targeted therapy, immune therapy, and supportive care for various organs. There is better infection control now as compared to earlier on. I mean, we virtually had no fungal drugs to control the fungal infection. We had no viral antivirals to control CMV and other infections, basically. Okay. So we have better infection control now and better organ support techniques in terms of ventilation or CRRT or other support system. So this has resulted into improved survival in cancer patients. So if you see the studies in last 2 decades, actually you'll find that combining the solid organ tumors and the hematological malignancies, the survival has improved from 15% to 50% overall, in both. And if you take combined outlook, you find that 67% of the patients have now 5-year survival rate, actually. Okay, so the cancer treatment has really, really evolved. So, looking at the situation of various other specialties like neurology and cardiology, who've had their units for a very, very long time, and they actually proved that it improved survival in their particular patients. They could operate early, they could recognize the signs of deterioration early, because they were trained to do that. Similarly, the oncocritical society, critical care now has become a distinct subspecialty, which is now focusing on early ICU admissions rather than delayed rescue. It is managing treatment-related toxicities like infection, tumor lysis syndromes, and recognizing them early as compared to, places which do not do this. People are not able to recognize what is going on with the patient, actually. So the biggest advantage in Onco ICU would be that you are integrating the oncology services along with critical care people. So you are taking decisions early. So the focus is now shifted from prognosis-based exclusion to individualized dynamic decision making, actually, which is improving the survival. So oncocritical care ICU is a thing which needs to be seen in virtually every hospital which is treating cancer patients. Now, 20% of my patients at present in the ICU are actually cancer patients. So they make a distinct group.
Yeah, that's true. And we should also mandate that now we have to upskill ourselves as well, the person who are
Yeah.
manning the units. Just like probably we have done in other units, you
Yeah.
might require a little bit, something maybe a little more than what you do with the general ICU. And that's where I asked my question to Dr. Chitra. What about a dedicated intensive care, just like we have for cardiovascular diseases and in neurosurgery units, intensive care? Where do you put dedicated oncocritical care unit?
Thanks for asking this. And before that, I want to thank Dr. Saurabh and Dr. Praveen for having me here. It's really a privilege. And yes, coming to the question that has been put by Dr. Rakesh, is that what is the role of dedicated onco ICU? See, it from the if we talk about from the investment purposes, it is not a recommended thing that we build onco ICU by default. It should be built where the cancer volume is there, expertise is there, and case mix, and you have that justify the investment. And having said that, that means that in areas where there is not oncology specialty as such is not there in the in hospital, or they are the footfalls are not that many, then from the cost effectiveness it doesn't make sense. But what you actually need is a closed high intensity general ICU where people are aware of. You have onco exposed intensivists, you have onco exposed pharmacists who know the interaction with the cancer drugs. You should have the onco trained nurses, and more importantly, you should have some onco specific protocols. Like, I totally agree what Dr. Abdesh has said, that onco subpopulation is very specific for certain kind of complications, like they are highly immunosuppressed. So as far as the infrastructure is concerned, one should have the facility to isolate them, have reverse barrier facility of this thing, positive pressure ventilation. Then stem cell transplant complications one should be aware of. Then we know these patients have cytokine release syndrome, and then you should have the facility for picking up HLH fast, and the plasmapheresis and all those chemo related management. Then we have to have all the in-house facility for working up these patients for opportunistic infections. That means, having said that, we should have the facility to sample, and the lab should be able to process those atypical opportunistic infections. That makes a sense. So it is not that we need a dedicated onco ICU. What we need a comprehensive collaborated onco care, which goes right from the oncologist to the lab people, to the pharma people, to the nurses. And have another thing that we have is that probably managing these patients in regular ICU, we should have some cancer specific pathways. Like, to name a few, it should be like neutropenic sepsis protocol, tumor lysis syndrome protocol, or CAR T therapy toxicity protocol, or platelet transfusion related protocols. What are the protocols if the chemotherapy extravasation occurs? What should be the transfusion thresholds? So all this, basically we should all be aware of what kind of complications may come in these kind of patients, because unlike a general ICU, patient management should be more anticipatory and preemptive in onco patients than what we see day to day. That's my take.
That is true. It does sensitize us when we have these dedicated units, and probably the same people working may pick up things faster. That is true. That we always see what happens to trainees when they join a new ICU, whichever kind. So when somebody joins mine ICU, which is heavy on medically ill patients, some of them find it difficult, and we find it difficult when we go to a trauma care. Although the basic principles remain the same, but still, I think it's equally important. That's where we were trying to meet on one of the areas that we can improve in. I have Rakhi chipping in.
Yes, Rakesh. So thank you,
Yeah.
Dr. Chitra. Yeah. So now the next important thing is about the competencies of the intensivists who are there in these oncocritical care units. So, like, according to you, what are the competencies that every onco-intensivist should develop? Or how should I put it? Like, how should we train ourselves to meet the growing demand of the care of the critically ill oncological patients? Dr. Sangamitra Mishra, ma'am?
Including people who
From
are there
you?
for 2
Yeah.
decades or more in ICU and trying to learn
Yeah.
oncocritical care. Even for those
Yes,
seasoned
yes.
intensivists,
Because I think
where do we get the edge?
Yeah.
Yes. Thank you very much, Dr. Saurabh and Dr. Parveen, for having me here. It is a great experience along with all of you. As you have told, from 2023, we have started this specialty. This competencies actually is during the training period itself. I was just going through the curricular framework of as defined by NMC or our NBE board. I was just seeing a lot of emphasis have been given on cardiovascular, neurological, sepsis, trauma, but hardly anything it is specified in oncology actually. So it is high time, as Dr. Saurav has told, because the number of oncological patients are increasing because our general age is increasing. So because this is mostly a geriatric issue, though younger and pediatric populations are also there, but number of patients are coming to get care. And therefore, because of the increased better care, immunotherapy and other personalized therapies also, the longevity is increasing. So we are facing lot of patients. That is one thing. Another thing is, as Dr. Rakesh told, uh, government is also planning in every state, in every district. Actually, we are having both government as well as corporate and semi-corporate oncological services. Exclusively onco hospitals are also there. And therefore, it is high time that our intensivist must develop this specific skills actually, which is required to care for a oncology patient. Not only I will tell oncology patient, it is about treating a team which involves their patient, because for an oncology patient, the family is one of the very important, they are very important people to decide the goal of the therapy. And therefore, one intensivist trainee, or even we are also trained, because there was, in our time, there was no specific oncological training, so oncocritical care. So understanding the patient population is very vital, like their age, their socioeconomic status, then associated comorbidities, then of course, as Madam told, Chitra Madam told, understanding the cancer biology and therapies, different types of immunotherapies, chemotherapies, and targeted therapies also. Then another important is, unlike general critical care, uh, it involves more comprehensive care. As sir has already told, sir has already told, oncologists, then oncosurgeons, then anesthesiologists, palliative people. Palliative team is very important. They come and go from those team visit very frequently the onco ICU actually. So having a collaborative team is very important. So those specific skills, little bit of those skills, pain management, palliative issues, then symptoms specifically related to oncological patient, like as I have told, nausea, vomiting, pain, and psychological and spiritual pain management also is very important, and distress of the family, distress of the patient, and integration of palliative care, that is important. And Chitra Madam has told, interdisciplinary collaboration is very much required. So the intensivist, onco-intensivist must always be ready to provide support for consultation, and also very ready, very resilient to take support from other specialists like oncologists, oncosurgeons. So with a little, there should not be any hindrance, and there should not be any inhibition to take because it is the best interest of the patient. Actually, collaborative service is required. So in most of the cases where it is a closed ICU, these skills are actually what I have seen from my experience over 20 years. Somehow these collaborative things are missing. So that has to be again brought back for the best interest of the patient. Then one of the most important thing is communication and empathy. In an ICU, actually, we get, because we are busy with all procedures and with resuscitation and all, we get very less time to actually discuss with the patient party. So it is always better whenever the patient enters, from the very beginning, we must decide what is the goal of the care, and that has to be patient centric. And we have to help them to take a decision when they are indecisive, and what is the outcome, how the patient will behave in future if he survives this ICU stay. What is in the future, that must be clearly discussed before patient develops any morbid events, because there is no time that at that point of time there is no time allowed for a vivid discussion. So that has to be documented from the very beginning. That is one thing. And cultural competencies also. We must understand the culture of the patient and their acceptance level. So we have to be very resilient in this context. To understand, we should not impose our thought or our idea or what we believe. Now, for example, I am just
Agreed,
telling
ma'am. Yeah.
recently
Yes,
one
agreed, ma'am.
patient. Yeah,
Yes, ma'am. You're telling something?
yeah.
You're
Recently,
sharing
actually, one.
something, ma'am? Yeah.
Yeah, yeah. Recently, one patient, the patient is still there. Actually, it is a case of lungs malignancy metastasis to bilateral parietal lobe. And for the last 1 year, the patient is not interested to leave. For last 1 year, to the family member is, I want to go. I want to go. That is an 83-year-old. And when patient was admitted, instead of very aggressive investigation, though the team wanted, the neurologist wanted to go for a very aggressive investigation, you must understand patient party is not interested. And hardly four months patient will survive if we go for very extensive investigation. Though they did all type of PET scan and all, and it was diagnosed, but ultimately there is a discussion, collaborative discussion, and patient uh, wanted to go to a palliative care. Their wishes are to be respected. So those things have to be developed during training period. That is one important thing. And those students who are interested to take oncocritical care as a specialty in future, they must be specifically trained to take care of themselves actually, because with oncocritical care, lot of burnout is involved. So they have to be um, focused on their self-care also. And another thing is, NMC has given 1 year outside the ICU. Out of 3 years training in a DM course, 1 year training outside the ICU. So those trainees should be given opportunity to work with the oncology department, oncosurgery, in theaters with the oncoanesthetist team and with the palliative team. So I see in most of the places this is not happening. So whenever we go for this, as Dr. Saurabh was telling, we are developing guidelines and all. We must emphasize on this. So if they work with the oncology team, definitely they develop lot of skill, and also for hematological malignancy in transfusion team and also in hematology. So they must work with the to develop a
Yes, ma'am.
comprehensive
Like
skill
we
actually.
have to be in tandem with the onco team also. So
True.
just to sum up,
And
like
it's as much
I
about
think we
soft
need
skills
to
as
be
it about
more.
hard
We
skills.
need to develop. Yes, Akishda.
It's a lot about soft skills also.
Yeah,
Yes,
soft
Yeah.
yes.
skills also. Yeah. So basically, like the now the onus is that we need to develop more like competent onco-specific protocols, and with like more emphasis on advanced documentation also. So now with that, I'll be going to the next question, Dr. Vandana. So like, how do we identify the oncological patients who are at risk of deterioration and should be transferred to the ICU? So is there a need for any onco-specific early warning scores? Dr. Vandana?
Yeah, right. Um, so if we look at it,
Let
we
me.
do not have any single
Yeah.
bedside, oncology early warning signs scoring system, which will look into the, early risk across all scenarios in these patients. So what we are using are the early warning sign scores, like the news and the news too, which is there, which we use for the standard patients who are there in the ward. But what we really need to keep in mind is that this onco patients would respond little differently than the rest patient, and the difference would come because of the blunted physiology, their reserve. Then these patients can show rapid deteriorations that needs to be kept in mind. And we also need to understand that all the disease specific risk which this patient would be showing us may not be captured in the early warning scoring system that we have. So this difference needs to be kept in mind, but then the early warning sign as we use in the rest of the patient can also be used in this patient, keeping the difference in mind. And of course, there is definitely, if as you're asking whether there is a need for onco-specific scoring system, of course it is there. But what we have, the early warning scoring system that we have needs to be augmented, but not replaced. Because we are used to the system, and the people who are manning these ICUs are the people who are used to this scoring system. So maybe certain things can be added on to it instead of replacing it, is what I would like to say.
Thank you, Vandaba. So, I would like to take the opinion of the other panelists also. So, does
So,
any, yeah,
yeah,
one
so
sir.
I can just say that you need to recognize high-risk features like neutropenia, sepsis, infection, respiratory distress, which is evident actually, okay, or rapidly progressing malignancies. So unfortunately, none of the scores like news or so far take into account of immunosuppression, tumor burden, and treatment toxicity. And we need to have certain scores which are going to take into account all these features actually. So a tailored oncology early warning score would actually improve ICU triage. Unfortunately, that is not available at this point, and there is a need to develop that. So severity assessment scores like SOFA, Apache, they have their limitations, and they cannot fully capture the critical need for the cancer patients. So early, assessment of high risk like neutropenia, sepsis, or respiratory distress is the most important feature which you need to watch out for.
So
Thank
for
you, sir.
febrile neutropenia, I think we have two scoring systems which looks into the risk of, but
Yeah,
then they are specific only for febrile neutropenia.
absolutely. Yeah,
We can merge them, both the scores, and
yeah,
then maybe
Yeah, so that's
take
exactly.
why
it.
I said
Yeah,
Yeah,
we should
yeah,
augment it instead of replace
yeah,
it.
exactly.
augment
Yeah,
it. Yeah,
yeah,
yes, ma'am.
absolutely.
And
And
Dr.
then
Avdesh, you're here. We would also like to know how is the patient demographics changing in terms of extremes of age, more younger people with treatable cancers now with newer protocols, and it's also about the onus of the costs involved, a productive person involved, or the with longevity. We are expecting people to live to the 90s. How do you see the patient population changing and the protocols also changing? What you apply to a young man, to an old man, is it all equal in cancer, or is it really a spectrum like pediatric oncology, geriatric oncology, or maybe the middle age oncology? How do you see patient demography?
I think the patient demography is definitely changing. We're seeing more younger patients now as compared to earlier on. And this is mainly because of the ease of diagnosis now, actually. Prior to, let's say 2 decades ago, the diagnoses were difficult. Now, leukemias and lymphomas are diagnosed much more frequently and much more easily as compared to earlier on. And these diseases are more aggressive, actually. Okay, so you have younger patients in the ICU. You have increased comorbidities, especially because of increasing obesity. You see a lot of diabetes, actually, which is contributing to the comorbidities of cancer patients. Cardiovascular disease, hypertension, especially, and heart failures, actually, which is happening much more in the younger patients. So you have rising cases of hematological malignancies, you have advanced solid tumors, and you see so many times when younger patients are admitted to the ICU, they're actually receiving active cancer therapy at the time of admission to the ICU. So you're seeing more younger patients to the ICU now as compared to earlier on. Uh, but obviously, it will depend on the cancer center also, what kind of population you draw and what kind of consultants you have working for a particular hospital. So, I mean, if you have a neonatal, oncologist, then obviously they would be seeing much more neonatal malignancies as compared to a hospital where general oncology services are being provided. So, younger patients, yes, but every sorts of admission is there.
So, and we often see before giving up on patients,
Yeah.
whether we should give them the chance is intensive care, because the landscape is changing, things are changing. People may believe that we might do something magical. Both to you and Dr. Chitra, what about this concept of trial of ICU? Giving 3-4 days and taking
I
a
think
call?
it's a very, very practical and ethical approach. You know why? Because it's kind of time-limited ICU care, which is normally for 3 to 5 days. And during this time, you're trying to reassess the response before continuing aggressive intervention. Okay, so you're basically trying to avoid both premature withdrawal and prolonged futile care. So you're trying to differentiate both the things basically. So what you do is you have clear operational goals. You have clear goals defined at admissions. You have daily reassessments of the organ function and their response. You are having transparent communication with the patient and the family, actually trying to find out as to what should happen before I decide not to continue with treatment. And then you have to have predefined endpoints. Okay, so within these 3 to 5 days, when you have, let's say, a tumor or a cancer which is aggressively worsening versus improvement, then you can decide, okay, I am not seeing any improvement and this is futile to continue with the treatment. So I've given the trial for 5 days, it's more than sufficient, I'll give it up. Okay, or versus within those 5 days, the patient has improved and I'll continue to have aggressive treatment. So I think it's a very ethical thing to do, to give a trial of ICU for 3 to 5 days.
I
Here,
fully agree
one
with.
thing I would like to ask.
Yeah.
So like this is commonly encountered in ICUs. So once we have explained about the futility of the treatment, so there are like suppose there are 2 or 3 family members who are responsible for taking the decision for the in charge of the patient, and then there are conflicting opinions. So how do we go about? Suppose the husband is agreeing to continuing all the aggressive support, and the son or the daughter is refusing, or they have agreed to the futility of the treatment and have agreed to the withdrawal of life support. So in that case, so how do we proceed without hurting anyone's sentiments?
So I have worked in the West where patient autonomy is the most important thing.
Yes, sir.
The patient is actually
Suppose
asked the
the
question
patient is
directly.
unconscious.
So
Suppose the
if the
patient is
patient, so
unconscious.
if the patient is unconscious,
Then the
let's say,
surrogate.
So
let's say,
whose decision will matter,
so
sir?
okay. So first of all, it's your decision to find out whether the patient is going to get better or not, and whether with the aggressive treatment of ICU trial, whether the patient is getting better or not. After 3 to 5 days, if you realize the patient is not getting better, then it is better to sit down with everybody and have a clear communication, okay? And then take consensus as to what you can do. I mean, you can only advise in today's day, you can only advise that this is in the best interest of the patient, right? But there are cases
Yes, so
like
we cannot be too
VVIPs.
patronizing also.
Exactly.
Yeah.
We can't be too patronizing also.
Yes,
Okay.
sir. Yes, sir.
And most of the VVIPs, if they get admitted to you, nobody will listen to you. Whether they want to
And
No
continue with
answer.
the treatment,
Yes.
they will all continue with the treatment. You know?
Dr. Rakhi, I would like to say
Yes.
here that, this concept of time limited trial is exactly being made not only for us, for the family to take, or for the family unanimously to take a decision. It is also
Unanimously to take the
addresses,
decision.
it addresses that issue also where there is a conflict of decision, that one person wants to
Decision. Yes.
pursue and the other doesn't
Pursue.
want to. So then it's a fair trial, that you give a balanced approach, that we try for 3 days, 5 days,
5
we
days.
see the objective improvement in things, and if it works, we pursue with the aggressive path. Otherwise, we go to the only
Yes,
palliative
that is what
care.
I wanted to highlight. Yes, yes,
Yeah.
yes. Got it. Got it. Got it. Got it.
And it's not just the family which is at conflict, it's also the medical
Yes.
team at conflict at times.
No, and most of the
I
time
think we also
it
don't
is.
agree.
No,
with each other.
oncologists are very aggressive these days. They are not ready to give up their patients.
Yes.
And
They
sometimes,
don't give
as
up only. They continue
and
till the very last.
yes, so that's why for
They don't
us
give up
also
so
to
easily.
convince them that it is
Yes.
not done, it's important to have this kind of a thing, with us. And
And
I think that's a
actually,
very
Yes,
practical
yes.
approach.
and
So an
Yes,
open
yes, yes.
communication, I think, would really make a lot of sense
Yeah,
here.
absolutely.
And
I mean,
when the
all in
patient
Yes.
specialty open communication.
when a
No,
patient
it's,
is
what
coming,
we had a therapeutic trial like ATT and PUO going on. So you give ATT for 15 days
Correct.
and see whether it breaks or not. So it's
Correct.
something like a therapeutic ICU trial for 3 to 5 days,
Yes.
and then see which way the patient is going. You are wiser after 3 days.
Then, Dr.
And it is
Chitra, in
about
this trial for ICU, we are shifting the patient into the ICU. and then suppose it doesn't, there is no point in carrying forward with the treatment, then again, like, how do they take, when we have to say that, okay, like, we can take the patient out of the ICU? So do they take
No,
it?
it is not you. They don't take it. We provide end of life care in the ICU, which is actually aimed towards a pain-free and a dignified death.
Yeah,
So,
comfort care.
yeah, comfort care.
Yeah.
So it is not that you are like, if somebody he's deteriorating and you try to shift him out. Unfortunately, I think there is a demand for end of life palliative ICU type of units, with the kind of cancer patient increasing and with even the lifespan increasing, we have to have some dedicated care. But unfortunately, as of now, we don't have. So we don't usually shift these patients to the ward. Sometimes they are too sick. They require whatever monitoring,
Yes.
feeding, and all that. But you do have a clear agenda written on their file that it is only a palliative supportive care where we are giving, where the only intention is to make him pain free. That's it. And
Yes, that is where the soft skills actually, yeah.
visits to the ICU.
Yes,
Instead of
yes.
having
Yes, yes.
twice
So,
in a day, we do it 3, 4, 6 times
Yeah.
visit so that the family can visit.
That is exactly why the soft skills count so much in an onco unit. So we really need to hone up on those skills. Otherwise,
yes,
there's a lot of
Yeah.
mismatch between the
communication.
communication and we don't
Absolutely.
communicate good enough for them
Yes.
to, yeah. So now coming to the next question. So like between solid tumors and hematological malignancies, Dr. Sangamitra, like which is the more challenging to manage? So in your clinical experience, like can you just cite the reasons and how you have managed those cases?
Actually, from an intensivist perspective, hematological malignancies are generally considered the more complex and high-stake challenge compared to solid tumors. I feel actually, while solid tumors patients often present with predictable mechanical issues, like for example, your airway obstruction by a mass or a post-operative complications. Hematological patient actually represent a perfect storm of physiological fragility. So I feel the hematological patients are more challenging. And as far as immune obliteration is concerned, unlike solid tumors, patient may have maybe immunocompromised or immunosuppressed, but hematology patients are often immune ablated completely. So neutropenic sepsis in these patients can progress from stable to septic shock in minutes. Last year we had a patient, we are just planning for a stem cell therapy and haplo transplant, but the patient actually developed a septic shock on the very same day, and patient expired in the morning, next day morning. So because they have virtually no physiological reserve, and multi-system volatility is also there. Like you are not managing a cancer, you are managing a fallout of aggressive induction chemotherapy or bone marrow transplant. These things actually include like your graft versus host disease or veno-occlusive diseases and complex coagulopathies, which are actually, though it is seen in solid tumor as well, but it is more common in hematological malignancy. And most often uh, there is a ambiguity in sometimes uh, in diagnosis, which is more visible in a solid tumor cases, but in like a patient of hematological malignancy, simple pulmonary infiltrate in hematology, say for example, it can be a common bacterium, an opportunistic fungus like aspergillus, or a viral infection, or alveolar hemorrhage, drug-induced toxicity. So this diagnostic tightrope is much thinner in this hematological malignancy cases. So I actually, for example, recently we had a dyspneic patient actually. In his, one of my relative is a 83-year-old patient. He had lungs malignancy, and he came with metastasis in the brain and worsening hypoxia. And he was just put on mechanical ventilation. There was associated pleural effusion, and after draining and all, he improved. But in a dyspneic patient in hematological malignancy, one I remember one young girl, 28-year-old, post allogenic stem cell transplant case. It was around 18 or 19 days of stem cell transplant, and she developed hypoxia. And we was really struggling whether it was a case of trally because she had been infused 12 units of platelets, and whether it's a fungal infection because she was coming and frequently coming to ICU, coming like that. And on last 3 months, she was on this
That's
antibiotics. So whether it is a idiopathic pneumonia syndrome, also we're really struggling for her, and whether we do for high dose steroid, whether we should provide or not, because it may underlying infection may get worsened. So this is
that
actually
How long did
dilemma
it take
for
to
the.
diagnose that, ma'am? How long did it take to diagnose the
No, it was
differentials?
found out to be
it is
tragedy actually.
Okay,
Uh,
okay.
so, but
actually.
initially we struggled actually. So, and the intensity of intervention actually is also higher. Risk involved is higher actually. And intubating a
And that
patient
is
carries a massive mortality risk. Yet delaying it could lead to a cardiac arrest. So margin of error is nearly zero in a hematological case. We have a dedicated hematological ICU. We are running the DM hematology course. So we are, and
and
referral cases are also coming. So actually the mortality rates are higher than solid malignancies. So
that is
actually,
why, as ma'am,
we often say solid tumors are a battle of anatomy, whereas
Yes,
hematological malignancy are
yes.
a battle of biology.
Mm.
So
Ma'am, yours is a dedicated unit. Like, how would you like advise us? How do we deal these patients in a general ICU, which is looked after by general intensivists like us? So,
and
like, how can we
we have a dedicated hematological ICU, six-bedded hemato-oncology ICU we have. And general ICU, multidisciplinary ICU, which are mostly closed ICUs, we have another 180 beds where we keep solid tumor and oncological cases we keep in our closed ICUs. But
and
for hematological ICU, isolation beds are there, and that is a dedicated one.
and
One intensivist, full-time intensivist is there. He is basically
Dr.
from a medicine
Parveen? Yeah.
background,
yeah.
professor of
So
medicine, but he is practicing
Yeah.
hemato-oncology mostly,
So,
critical care.
Dr. Rakhi, and
Dr.
that is
Parveen?
why,
Yeah.
yeah, that is why we are talking about working in a dedicated cancer ICU unit. Because if you see these patients regularly, then you will come to know there will be many differentials at one point, and then you have to, whatever needs to be done, it has to be done in a very short span of time. You will be having one event, and then you are taking care of that, so different. So that is why the importance of this dedicated onco ICUs come
Yes,
in these patients only.
I really agree with this.
Lot
Required.
of infections you will see, which you many of them I have not even heard their name of, when the culture comes positive. And it is today only I was seeing one BK cystitis and was wondering, acha, is it that normal? So but all hemat people were telling us that it is BK cystitis, BK virus cystitis. So I read about it, and it is about after 6 years working in an onco ICU, and that is why I'm telling. And I will, I don't know, but generally, if you work in a multi-speciality ICU, we will not thinking of BK cystitis, especially
So
indirectly.
Yes, yes, ma'am. That's exactly
if
where our
you if
problem is.
if you talk
Yeah.
to renal transplant patients, they will tell you BK
They,
cystitis is a very
yes,
common thing.
yeah,
True.
that is why, na, sir. But then the renal transplant patients will be. Then I just read, and then I
Yeah,
thought, ki, okay, I forgot about it. Probably that is very
uh,
common in these patients.
exactly. It's very common.
Yeah.
Yeah.
Okay.
And as we draw an end to our conversation today, it's about we talk about end of life care and palliative care, and often both are confused. I think EON is something we have practiced, and palliative care is a term which probably came from cancer. What
Yeah.
is your word on palliative care? And then Dr. Vandana to conclude with EOL, how different, how same? Dr. Bansal.
So let me start by saying that there is a clear difference between what is palliative care and what is end of life care. Now, palliative care is something
Absolutely.
which goes on throughout the disease. The aim is to
Absolutely.
improve quality of life. Okay, that's the most important thing. Quality of life needs to be improved with palliative care, whereas end of life care is the final phase which focus on comfort and dignity. Okay, so
Absolutely.
there are core principles of palliative care, and one of the core principle is symptom relief. Okay, which is either dyspnea, pain, or anxiety. Okay, these three things need to be taken care when you're looking at the palliative care. Also, it needs to be integrated early with the patient care, which means that this is not something which starts towards the end. It starts with the treatment of the cancer. Okay,
Yes.
so the palliative care actually goes on throughout the treatment, frankly, okay? Whereas end of the life is something which is happening towards. Now, communication with the patient and the family is really, really important when you look at the palliative care. So you have to align care with patient goals. So it's very, very important. So palliative care would have, I mean, we have a palliative care specialist who comes and sort of looks after. The main thing they do is talk to the patient and the patient relative and discuss their anxiety issues as to what's going to happen. I know one of the biggest issues at times is the rising treatment cost. Okay. And they become so anxious that if they're not counseled properly, they'll leave the treatment in between and go away. So it's really, really important to have proper palliative care. End of the life care is something when you decide that it is now futile to continue with aggressive treatment, you've decided this is the end of the road, and now you have to keep the patient comfortable. So it's like tender loving care, okay, where you continue with some essential things like, I mean, we tend to continue with feeding and the fluids actually, okay, but we kind of discontinue with the patient and the family consent, things which are not going to add to the treatment of the patient actually, okay. This is just continue with the life of the patient endlessly without any end result, basically any better outcome, basically, okay. So it's important to do palliative care from the beginning to the end.
I think
That
palliative care
means,
is
as Dr. Desh has said very rightly, so all end of life care are a part of palliative
Part
care,
of
but not
palliative
all
care.
palliative care is
Yeah,
end of life.
Absolutely.
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 Yeah,
This upset
and
and yeah,
most of the people will confuse the moment the term palliative care comes. Patient, this mindset has to be changed that this is not the end of the road. Palliative care
absolutely.
is
End
more
of life.
about your
Hmm.
quality of life.
Quality
You
of
have to
life. Yeah,
support them, and the psychological support is one of the very, very important things, especially in any chronic disease, be it COPD, be
absolutely.
it heart failure.
yeah,
That is very, very important.
absolutely.
Absolutely.
Thank you.
Correct.
So now when it comes to like research on therapeutic interventions, so we always consider either death or survival as the outcome. So death, as we all know, is inevitable. So can we consider quality of death, not just death, but quality of death as a legitimate and meaningful outcome in all these clinical trials or interventions? So how should it be, like your take, everyone's take? We'd just like to have an idea.
I would
Yeah,
like to say, if you remember cardiac patients, sometimes you say, oh, the patient died in the sleep, actually. What a
Hmm.
comfortable life this patient had, and what a comfortable death he had. He did not suffer, he had no chest pains, he had no shortness of breath, he was not intubated.
He just died.
He had a good death, okay? And we all know that, okay? So
Yes.
I think the quality of death is an important outcome, actually, okay? And it can be measured by symptom control, patient dignity, family
Yes.
satisfaction, very,
Yes.
very important, family
Yes,
satisfaction.
yes.
And
Yes.
tools like, QODD scores, actually, which can actually decide whether you've had good death quality.
Correct.
Here, I would like to share one of my experience that
Yeah.
the end of life care and dignified exit. I remember it was in during my fellowship days at Gangaram Hospital. One
Hmm.
obstetric gynecologist, she had a breast cancer and she was visiting our ICU frequently for pleural effusion actually. So for the third time when she visited, we were just planning for pleurodesis. But unfortunately, the chemotherapeutic management failed, and we decided not to go for. So at the end, when she was there in the ICU, when their family members asked her to take home, she told no, I will stay here because as the Gangaram ICU was becoming her second home like that.
Hmm.
So we just modified. There I learned a lot of things like empathy and how, as a team, we can support the family. We just put the bed in the center and uh, we took out the bed. We just kept the mattress in two mattress in the centers so that she had two twin in the class ninth. Her husband
Hmm.
and two children. They were around her, and that night I was in emergency, and everybody, all the intensivists, frequently coming, and when the children were asking, "Is she having pain?" Then somebody was telling, "No, she is tired. Why she is not talking to us?" She is tired. She has a lot of things she has already told you. Just remember what she has told you. Like that, we just gave a lot of support throughout till her last breath. So I think that was very comfortable for the
Yeah,
family, because any of us were available
absolutely.
to take a query, whatever, any simple
Yeah,
query they are asking. Anybody, any qualified intensivist was at the standby inside the ICU to take that question and appropriately answer them. So I think that was a dignified exit for her, and also for the family got
yeah,
a proper support.
Yes.
So that
So
should
that
True.
be.
is what, like, yeah. So oncocritical care is like no longer about whether we can treat these patients, but about how thoughtfully, wisely, and humanly we can treat these patients.
Yeah.
absolutely.
And absolutely,
Yes.
now that, with the Supreme Court verdict on end of life care, which has come to the
Yes.
Yeah,
center stage, that's why, as Dr. Pansal had said, that the dignified death, you know,
Yes.
dignity in death, which is also should be, in the mind of all the treating intensivist physicians who are associated with these patients, because otherwise, the other option, if we do not do that, other option is a lama and the patient, dying somewhere, but that is not something which any one of us who are associated with a patient would want. Hence, I
Mm.
would also say, as
So
Dr. Bansal
now,
has put forward, that, death in, dignified death is something which becomes a responsibility for all of us caregivers who
now
absolutely.
in
which
our
have
I
to
would
live
Exactly.
like
with.
Yeah.
to add one more thing over here, if the panelists may allow. It is not only this dignified death. When you are talking of quality of death, you are also, although as Indians, we have not evolved to that extent, but advanced directives have been coming, especially from some influential families, and also it is also the quality of death is also one of the goal is to did the treatment align with patient wishes, were
Patient.
advanced
Yeah,
directives respected,
Patient
yeah,
was
centered.
care consistent with patient values,
Yes,
was
yeah,
unwanted escalation avoided. So these things also, I
mhm,
think, come and they form a very important part of
yeah,
the care.
absolutely.
Yes.
Yeah,
absolutely,
I agree.
Absolutely.
absolutely.
Yeah,
Yes.
Patient
Yeah.
has to
Absolutely.
be in the
Can
center
I
of all.
Yes.
can I talk for a few
yeah,
minutes in between?
Yes, Sonaiba.
Yeah, yeah, yeah.
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 The meeting is now open to participants. You can put in a
Yes,
chat question. You can
because we have
unmute and
many
ask
people here who are working in
it.
onco units. Dr. Sonai.
Yeah, so I'm Dr. Sodai. I'm working in the oncocritical care ICU only for the last 5 years. I'm working in B. Borwa Cancer Institute in Guwahati. So what I want to share is that the difference, because before working in BBCI, I was working in other ICUs for around 14 15 years. I worked in all kinds of ICU, like trauma ICU, medical ICU, general ICUs. But suddenly there has been shift, and then I was only taking care of oncocritical care ICU for last 5 years. So the challenges that I faced was the types of patients, the type of disease. There was pediatric patients also, young also, than the old people also. Then there was, you need to be aware of this. You have to study about all those medical emergencies, about leukemias, about all those hematological medical diseases, the chemotherapy side effects, then the different kinds of symptoms they present with. So this was a different thing. I had to be updated myself with all these things, multiple myeloma, plasmapheresis, and all those things. And the second thing challenge was the in other ICU we are like when we are working in other ICU, we want to treat everything, we want to do everything, we are very active. Oh, patient has come, we will do this, we will put lines, we will intubate. But here it is little bit different. Here we have to talk with them, even we have to consult the medical oncologist, the hemato transfusion medicine people, because here like you have to weigh with the outcome of the patient, the prognosis and the infection that they might catch. So suddenly
yeah,
you just cannot put lines if you want to also. Even they will be having all sort of coagulopathies, platelets will be low, counts will be zero, sometimes 1 2. So the need is for, like, you have to think about all these things. You cannot cannot just jump into this. For each patient, you have to talk, you have to consider all the aspects, and then a proper dedicated medical ICU, especially because they need a proper, very strict infection control, because they are very prone to all these opportunistic infections, very rare infections they catches. And the next is the counseling part, because this is the challenge. This is a very difficult challenge we face to counsel them. So a dedicated counselor, I feel a dedicated counselor, and especially the counseling doesn't actually needs to be happen when they get admitted to the hospital, other than when they are getting transferred to ICU. It's very difficult. So we need a
Yeah.
team involving the palliative care people, a team involving us, a counselor, psychological counselor. We have to involve the family, a person who takes responsibility of this. Then there are many issues like about the cost of treatment, the lack of beds, and all those things are there. But then we have to be very empathic towards them,
Yeah.
because I've seen the people, they sometimes they become very anxious, they have become very irritable, they will throw things out, and
Yeah.
sometimes they'll be very depressive. So you
Yeah.
have to, when we are caring for them, we have to be very empathic during rounds and all. We have to talk with them frequently. And one more thing I face, that challenges regarding some protocol should be there for the oncocritical care patients. Like sometimes, like the protocols which we follow
Yeah.
in
So
general
nice.
ICU,
Specific
like we are
onco
Yeah.
very,
So
protocols.
yeah.
Yeah.
so
Yeah.
giving
So nice.
platelet or
Yeah.
PRBCs and all. So all these
We
things
agree.
we need
Yeah.
this.
So we agree with all that. Basically, the Onco ICU is nothing but an integration of oncology,
With the
critical care,
critical
and
care
palliative
service.
medicine. Okay, three
Yes.
things basically. And the
Yes.
future actually lies in early intervention, personalized care. Actually, okay, that
And
is the
so
most
one more
important
thing,
thing.
they are referred
Yeah,
very late. What we
yeah.
feel is that
So
they
that's
are
what I
very
said.
referred very
Early.
late to ICU,
So, so
and
that's why I
then
said early
like
intervention. Yeah,
yes,
early
they are very
intervention is
referred
is
late.
is,
So
is the most important thing. Okay,
especially
great.
hematological cases.
Yeah, thank you. Yeah, Praveen.
So we are closing for the day,
Yeah.
but we are here in the
Yeah,
learning
over to
curve,
Saurabh.
and
I think Saurabh would
the
like to
whole
add on something. Dr.
yes,
Parveen.
and the whole idea of getting everybody on
Is
Oh,
board is
Saurabh
how
there?
we should move
So we
forward,
Yes.
have like
how we can use the technology, how we can take forward the education of
yeah.
practicing intensivists or students here, large number of students here in different training programs, how we can integrate, how can we can take help. I think Saurav is there to add the last word.
Is
Uh,
Saurabh there?
Actually, I learned a lot from you. Thank you,
Actually, regarding
Bandaram.
research, if you permit 1 minute, Saurabh, regarding research, as Dr. Rakesh
Mm,
told, something was coming to my mind, like longitudinal research, because in India we do not have adequate data also, and in the era of AI, all bogus publications are coming. So, will it be okay if we start, suppose in a DNB program or DRNB program or DM program, we have this longitudinal research, like because these are long duration cases. So if the patients are followed up by the third batch, again another batch is coming, they will follow up, the guide remaining the same, but the students keep on following and they will publish their duration data. And as we had a DigiLocker facility now with Ayushman Bharat Digital Mission (ABDM), I have a this startup company. We have a health locker facility, so there we can have patient data as well as patient research data. So that will go a long way to generate good data and these experimental therapies, outcome of these therapies, and we can get actual real information and proper information in Indian context. So that should be
And
can be developed
yeah.
for the DM training program and for the intensivist, young intensivist.
Uh,
So, just at the end, I want to say, like, the some concept that has originated in onco issue, like, or in oncology, like looking death, good death as one of outcome, opening our doors, asking doors to the patient attendant,
cancer patients
talking about
attend.
no ICU trials, separating palliative and end of life like separately, early integration of palliative care and end of life care. Ultimately, although this concept they have started in the oncology, but ultimately this will spread to the other issues also. And we all know that treating onco patient, critically ill onco are challenging. So if we work in Onco ICU, we'll be, I think, a better doctor, and moreover, we'll be a better human. We'll understand in human a different. So I think we can hear, and thank you again, Bandana ma'am, Sangamitra ma'am, Bansal sir, and Chitra ma'am, for your wisdom and insight, and also Rakesh and Rakhi and Sonai, and Rakhi and Rakesh for moderating so nicely. Dr. Probin, if you want to say something, then
I just
you can
want to
close.
thank everyone. I'm really glad to see that now at least we are talking about onco ICUs, that the fixed notion ki cancer patient है छोड़ दो इसमें कुछ नहीं करना.
बिल्कुल.
I think that is the biggest change we are
Yeah,
looking for.
yeah.
And as sir rightly said, I have worked in Apollo ICU. Hardly there were any patients at that time, and we were always
Yeah.
short of beds.
Exactly.
So now if we are thinking of separate onco ICUs, that also itself says lot of things about it. So I would like
Absolutely.
to thank everyone. Thank you, sir. Thank you, ma'ams. And it was very,
Yeah.
very nice and engaging discussion. Thank you
Thank
so
you,
much.
Thank you
Praveen.
so much.
Thank
Thank
you,
you, Praveen.
Saurabh.
Thank
Thank
you,
you.
Dr.
I'll
Das.
review it again.
Thank you
Thank
for
you,
having
everyone.
everybody.
Yeah.
Bye-bye.
Sure. Okay. Bye-bye. Good
Thank
night.
you.
Bye. Good night.